I'm from Guangzhou, China. Actually, our hospital is located in the downtown Guangzhou. Last year, our center done around 7,000 PCI and maybe more than 1,000 surgery. So our team has a lot of operators. They just take care of the maybe chip, maybe CTO every day. So when we're talking about the chip, I think everybody sitting here know about that, right? Not even the lesion, the patient probably got a very bad condition. So when we're doing the PCI, probably we look at the syntax score. So in China right now, there's some tough case right now. Actually, in the big center right now, it's kind of more and more tough case because the small center maybe take care of the acute case, and then when they got trouble or difficult one, they send to the big center. So in our center, probably have to take care a lot of left main, CTO, triple vessel disease, calcification, something like that. So when we're doing that, probably we need some good tool, right? Just now Joe mentioned we need to have the good guiding extension, something like that, good wire, everything. If you don't have, probably you will got the whole things mixed up. Maybe you got a very bad complications. So what's the good tool? Probably APT doing a very good job in the recent 10 years. They have a good wire, good microcatheter, good guide extension. So Joe already mentioned the guide extension. There's a side hole there. The side hole guide extension is very useful sometimes. I will show you later on. So here's the case. In this case, probably our team did something wrong. You can stop me and then make a discussion and go through that. Okay. There's quite a young patient. Is a 62 gentleman who had unstable angina for 2 months, have hypertension, diabetes, he's smoker. And when he come to us, it's quite stable condition. So the renal function is good, the heart function is good. He got a mild AR only. He has a dilated ascending aorta. So let's look at the angiogram. So we can see the left main, we can see the LAD, and also the second flex. It's a very bad, right? Diffuse, maybe calcification, a lot of located, no matter the left main, even the LAD or second flex. So we just detected by the QFR. So from the left main to LAD is 0.55. And the circumflex is 0.76. Also, we look at the right coronary. We can see the calcification a lot. There is a lot of shadow there. The full of the whole right coronary artery. So the stenosis, it looks not so severe. Actually, if you look at it very carefully, there's a very high-grade stenosis located at proximal of RCA. So the QFR right there is 0.39. So how about a strategy? You guys can make some comment in this point. It's no doubt you will ask the surgeon. Just go ahead. You are center, probably the surgeon can.
I'm not sure, because if you look at the distal RCA, that's not a good target for surgery.
Yeah, right.
Probably the right is probably an interventional thing. And regarding the left system, you have a lot of calcium, you have a high CT score. Probably I would ask the surgeon if you can at least do a mid cap.
Mid cap actually for LAD, what do you think? Right here. That's the LAD.
But you have a very poor target for the surgeon
right
here. I was wrong. No, it's
Any surgeon here?
I think there is if we decided to do it interventionally, and let's say that the surgeon says no, not operable.
Actually,
I will do rota in the LAD because there's calcium.
Actually, we just talked with the family and the surgeon. The surgeon said it's never say is no. They say it's a very high risk, right? And then they will talk to the family and make a whole decision. So finally, the patient just come back to the cardiologist and to us. So our strategy going to be the first attempt should be the right one. You guys are
I'm pretty happy to hear that in China it's the same as it is in Switzerland, because we would have a discussion. I think it's a proper way to do a discussion in the heart team in this
Yes.
case. You have to do it because everyone has to decide this is the right strategy. And I'm sure that our surgeon would say, super, we do it.
Okay.
But that's not the case. And I'm sure the patient will come back with the Lima not working, probably the circumflex as well, and the RCA is not supported. So he will end up having a surgery done for nothing.
Right. Yes. So if you do that to the RCA, what's your strategy? It's no doubt you will take an iris, maybe. Get ready the NC balloon, maybe shockwave balloon, maybe a rotor, even something else, maybe laser something. And the patient even have a very good ejection fraction. Do you think about the mechanical cardiac support during the procedure? Yeah. Anything think about that? Get ready that even.
If the function is good, why?
Okay, sure.
There
Yeah.
is no benefits. No benefits if the ejection fraction
Good,
is
right?
good. So
That's good
the
point.
mechanical support is.
That's a good point. Yeah. Okay, we go. Just go ahead. Okay.
Why did you select RC as a first?
Well, the left side is very complicated. I think if
Yeah.
you want to do that,
Because I think left main has problem. Isn't it better to stay the left main and after that? Because when you, for example, induce ischemia for a case during the procedure, left main may make problem. I don't know, just.
yeah, you're right. It's why I tried it. So this case is quite difficult. Do both. Maybe you do the left main and then you have to take care of the LAD and circumference. Very difficult. A lot of technical issue if you do that. For me, right? Maybe wrong, but actually we just make a decision and then went ahead to do the RCA. Yeah. Okay, we can talk about later. All right. So that's the strategy. All the device. I think everybody will reuse the M plus Y, M plus guiding. Yeah. And enrich wire, workhorse wire, and get through the lesion very easily. And for about then, I want to do the iris, it's no doubt, right? But the iris cannot go through. We just put the whole thing down. The pressure, the heartbeat is getting down. So we have to get some medication there. And finally stabilize the patient a little bit. So we just consider to go ahead use the balloon to dilate that and try our best. So the balloon, a small balloon, is get through quite well. You can see the 1.5, 2.0 can get through. Okay. When we dilate the balloon, we cannot see very well. We cannot see very clear is any waste there. So we just think about that's good. So we just finish up the iris. Actually, in this point, the iris cannot go through the whole segment. Just start in the middle of the RCA. But this time, because the patient already under the medication, quite a stable hemodynamic situation, quite stable. But we got trouble, the balloon, the iris cannot go. So we're thinking about, just Joe mentioned, we need the guide extension. Yeah. But for this patient is the routine guide extension is I don't think it's quite safe because totally block the flow when you do the guide extension in section. So we just do the displacement with four side hole. So how to decide for that? You can see there's two four side hole and two in the proximal, two in distal. Yeah, that's the design. From the tip to proximal 3 centimeter, there's a two side hole, and then go to proximal, there's another two side hole. So when we push the guide extension in the right coronary, we can see the guiding pressure is a get down, but the preflow pressure is still there. It's 100 something, 100 over 70. So the patient got quite stable. So I use the technique as similar to Joe mentioned just now. But for me, I use the 2.0 or 2.5 balloon, just pre through the guide extension, just pre through the whole thing. You just dilate it about 6, and you get ready to push. When you deflate, you just push. Okay, step by step. But anyway, you can see the guide extension is go through not quite easy because tortuosity and you can see the calcification there. So in this time, we're thinking about use shockwave. Shockwave, the first shockwave balloon is 2.5 by 12. Yeah, but actually we just go a couple of times and the shockwave balloon just rupture. Yeah, just 3 times and rupture. Just located in the proximal of RCA. So what's the next? Use another one maybe. Yeah, because of calcification probably just. Yeah, okay. Yeah, good point. So in this point, if we try to do the iris, still supported by the guide extension, the iris can go through a little bit. You can take a look. Full of calcium there in the proximal. Yeah. We just cannot push the iris all the way down to the RC. You can see the ring there. See the ring? Very tight. So this the some more detail. So the most tiniest lesion just located in the first curve of the right corner. It's very tight there. There's a ring. So that's the problem. Why everything cannot pass through? So we try to use the shockwave balloon again. There's a bigger balloon. It's 3.0 by 12. We just go short 7 times, but still can get just start there. You can see that the curve just start there. So cannot pass that. So we just right after that, we check the iris again, but the ring's still there. So that's why. So that's the point you just mentioned. Think about the rotor, right? But before that, we just use the high pressure balloon. There's a 2.75. We can see the dog bone phenomenon there. So this time you have to use the rotor. It's no doubt. Okay.
You didn't
We have a laser.
You didn't choose cutting balloon or storing balloon to.
No,
to try.
no. I don't think can pass through. Yeah, because the shockwave balloon cannot pass through. Okay, sure. Oh, so this time we use ELOT 2.6 French taper tip and then exchange the wire, rotor wire. And that's the point. Watch the movie. First run. You can see the heartbeat getting down and down and down and stop. The whole heartbeat stop at that time. So what can you do? I just thinking about balloon pump and the piston wire. So initially nobody think about to use the balloon pump, even the pacing wire, right? But in this point you have to use that. Otherwise you cannot stabilize the patient. So right after then the patient got stable and we able to do that again. We just get 4 runs. And every did that, you can see the heartbeat is getting slow, but we have secure by the pacing wire. So after this approach, I believe you can use balloon. This time, 2.75 balloon is fully open up. So iris again. Iris, we can see the ring almost still there, but there's a rupture. There's about the 7 o'clock, there's a rupture there. So I think we can go ahead and do something. So balloon, and then we just actually push the guide extension all the way down. You can see the cine in the right side. There's some contrast stent, right? There's a very long stent we just put in. When we inflate that, the stent balloon rupture. You just go ahead, go very fast. Try to open up the stent a little bit. And actually, as you know, because the balloon already ruptured, the stent cannot open up very well. So in this time, what can you do? You have to pull out the balloon, right? You have to pull out the balloon. Inflate and pull out the balloon. What? Yeah, well, the big point is when you pull out the balloon, the stem may become back a little bit and followed by
The wire is remain inside.
what?
The wire is remain inside the stent.
Okay.
And you inflate the stent, the balloon is ruptured.
Yes.
You cannot put balance here.
Well, yeah, that's the problem. Yeah.
Because it's attached to the calcified.
Yes. The calcite maybe stick on the balloon.
The
The
balloon
calcify. Yeah. Stem balloon stick by the calcification. When you put in. Yeah, I think so. Yeah, there's a long way to go. Even protected by the guide extension. The guide extension, you can see in here, it always go to the mid, the mid RCA already, and then push the long stand. Actually, the long stand already in place. You just go ahead to inflate that. We found that contrast just pull out. So we just go ahead very quick, try to open up the stand a little bit, and then pull out the balloon, and then use another balloon, small balloon. Yes. Should do that.
Same condition, same.
Yeah, the problem is you have to pull out the stem balloon and very slowly. And in this time, I use the guide extension just all the way down and barely touch the stem, and then pull out the balloon. Very carefully. But
Smaller size balloon, and you see step by
yes. Right after that, we use a small balloon step by step, and even the high pressure balloon. Actually, the stem just follow the balloon a little bit back, so we have to put another stem to the distal for the first stem. Okay. That's the stem. Okay.
Sorry.
Yes.
Did you prepare the lesion before putting the distal stent?
Yes, of course. Yes.
And the balloon were
It's good.
offered in
It's good.
orthogonal views?
Yeah, it's good. Yeah. For the calcification, always prepare by balloon. Always. And post test, you can see the balloon go through well.
And you didn't even reach the nominal pressure when you were inflating the balloon stand.
Actually, when you inflate that, you found that the pressure is not going up. Yeah, you can see the contrast full of the segment. So you can find the balloon rupture. The balloon contrast just blow out. Yeah, right. Yeah, that's
So
that's
it
the
was.
thing. When you deflate that, the whole blood is coming back.
What type of stent?
Well, it's a long stem, probably from some big company. Yeah. Yeah, that's the whole bunch stem. That's the final. Of course, final we use a high pressure balloon and check with iris and get them the case. So right with them, we just pull out the patient wire. The patient doing good, but the next day we just bring the IBP. Yeah. So probably I will bring the patient back around 1 or 2 months later and take the left side.
One question. Between different assistance devices, for example, you have intrathecal pump, iPad, something like that. There is a selection or not?
Because that's the only device we have. Yeah, we don't have impeller.
You have?
Yeah, I have probably I use impeller maybe. Yeah, that's maybe yeah. But balloon pump right now that's the only MCS in China. The IVEC 1 liter, 2 liter is on trial. Pneumatic trials. It's not indicated to use that because they just suitable for the low ejection fraction. It's less than 35%. So that's the last one. You guys can raise some question. We can discussion.
I like your case. It's amazing. Thanks for sharing. Actually, my center is doing a lot of proper automations. Just one comment, you spend a long while doing some predilation with the 1.5 and 2 overlay. I would prefer, my strategy would be put a rotor wire down, do a 1.5 run initially, because you obviously have calcium, ton of calcium, and you'll probably save a lot of time. Also knowing that there is a lot of myocardium on jeopardy, and that the patient can get instable, you should calculate it if you have a case like this, because every native vessel is diseased. That the risk of getting hypotension or a cardiac arrest is obviously high, as you already said, also to the patient. But I would calculate the risk, and I think it is a lot easier to maneuver everything down and to treat the vessel, as you eventually also did, if you do a rotablation initially.
Yeah, for the distal road ablation, probably at that time we are triggered, right? If you touch too much, slow flow, something will happen. Every time you touch the lesion, the blood pressure down and the heart rate down. Every time you just got forwards at that time and stop.
Do you have any plan for PDA?
And PDA, not this time.
Because as
Yeah.
you know, all the trials for distance and
Yeah, we got enough. Probably we can see the flow is good. Just stop by there. Probably maybe next time we can check with that. If you got problems, maybe next time. Maybe I don't know.
and what was the duration of the procedure?
Actually, at least 3 hours. At least 3 hours. We take a lot of effort to take care of that.
And one more time, if the family of the case refuse to see you in your country, can you say that no, the PCI is not feasible, you must go just only for
Yes, but you have to talk to the surgeon. The surgeon just almost refuse. Well, all the surgeons are very smart. They just talk to the family, and then the family will give up the surgery. Yeah, if you want to talk that, it's quite easy, right?
Yeah.
Yeah. You never say I don't want to do that, but you can say something else.
And did you try to do some rota in the distal part with the guide extension catheter put in distally in the RCA, no? And then came with the rota to do the distal part of the RCA.
Yeah, actually, that's a good question. We try the rotor is 1.5, cannot go through the expression. 1.5, yeah. If you want to do that, you have to 1.5 per cannot go through the
The 7 French expressment is compatible with 1.5.
Yeah, but we tried it before. It's a little
Then
bit
you have
tight.
to preload it, then it's possible.
Right.
What you actually can do if it's really tight, you can put your guide extension catheter just outside of the patient. You advance your rotor burr
Yes.
through the distal bit of it, and you advance the whole bundle through. And then you actually can do it. If it's tight, but usually I've done it with a 7 French and a 1.5 burr, and it was quite tight, but it worked.
Yeah.
In some way.
We tried that before, but it's difficult.
Yeah.
But as you mentioned, the patient got a not very good condition. You have to roll the brake too much, you got trouble. I'm worried about the slow flow. Okay. So summary is no doubt everybody know that we just facing the trip every day, right? The hard tip decision making, interventional expertise, or facilitate with some new device. Displacement is a good tool. In this patient, probably we need that to support. We gotta flow that to support it. I think that's the key to success and get on the case this moment.